but it's really my honor and privilege to introduce our next speaker, and that's Dr. Park. So Dr. Park is a nephrologist and clinical researcher at University of California in San Francisco. Her research focuses on lifestyle factors and cardiovascular outcomes in individuals affected by kidney disease, especially those affected by polycystic kidney disease and other genetic diseases, including APOL1. So she's a co-PI of the UCSF Clinical Center for the NIH-NIDDK APOLO study, and is also the founder and director of the UCSF Polycystic Kidney Disease Center of Excellence. And I can just tell you, we want collaboration between different academic programs, academic centers, especially the UC programs as well. And I can tell you, Dr. Park has been amazing. So with that, Dr. Park, and you will be doing a more deeper dive into ADPKD and APOL1. So thank you very much. I like your green ribbon.
Thank you so much. I like yours. All right, great. Thank you so much, Dr. Rastogi, and the organizers of this session for the opportunity to present. I actually modified the title a little bit to say that this discussion is a deep-ish dive because we don't really have all that much time, and both of these topics are extremely large and interesting and exciting. So we'll do our best to get as much of an overview as possible. These are my disclosures. And I wanted to start with my take-home points so that you can keep these in mind as we go through our cases. I want you to come away from this knowing that genetic testing may reveal information that seemingly conflicts with other clinical information about risk of rapid progression in ADPKD. Genetic testing may reveal alternative diagnoses, and APOL1 genetic testing may eventually help to identify at-risk individuals, but uncertainties exist regarding the clinical implications. So let's get to my first case. This is a 38-year-old woman recently diagnosed with ADPKD in the setting of hypertensive emergency, which presented as epistaxis. In the emergency room during her evaluation for this, she was found to have bilateral kidney cysts and liver cysts. Her family history is notable for a father with diabetes and kidney cysts. He's currently age 70 with a GFR of 55 by report, and he's not on dialysis. She said that she had not been aware that he had kidney cysts because the father has always considered diabetes to be his major medical problem and didn't think the kidney cysts were really important. The patient's current GFR is about 100, calculated from a serum creatinine of 0.75. And her daughter, at the age of 8.5, for a variety of reasons, was actually recently diagnosed with bilateral kidney cysts as well. So this is not meant to be a talk about management of polycystic kidney disease, but just to give you a sense of how I go about caring for my patients with PKD. We're fortunate to be able to get total kidney volume measurements on most of our patients. And this patient's imaging revealed that she falls into so-called class 1C of the Mayo Clinic Erasmus classification of total kidney volume to assess risk of rapid progression in ADPKD. So this is the figure from the very heavily relied upon quote-unquote practical guide for prescription of tolvaptan and assessment of clinical care for polycystic kidney disease patients. And as you can see, one of the major branch points comes at the point of trying to measure total kidney volume by CT or MRI and determination of the Mayo class. So since we had this detailed imaging, it might be a question of why we would need to pursue genetic testing, if at all. And to talk a little bit about the rationale for testing in this patient, I think that the concept of shared decision-making is very important. She was relatively thrown off and shocked by this diagnosis, had been very healthy most of her life, was not aware of her father's kidney cyst issue, was very disturbed to find that her daughter was also recently diagnosed with bilateral cysts. So she thought that it would be very important to have the genetic information available to her to just understand the diagnosis better. So we did pursue genetic testing and indeed found a pathogenic mutation, which happened to be in the PKD2 gene, consistent with a diagnosis of autosomal dominant polycystic kidney disease. So to talk briefly about PKD1 versus PKD2, PKD1 comprises about 60 to 80% of all ADPKD pathogenic mutations thus far described. PKD2, which encodes the polycystin 2 protein, comprises about 15 to 25%. And in evaluations of individuals with a PKD phenotype, no mutation is detected in about 10 to 15% of patients. So-called additional cystic kidney disease genes such as GANAB and DNAGB11 comprise less than 1% of the molecular diagnosis for individuals with PKD phenotypes. So what to do now with this information? Technically, she meets the threshold for so-called risk of rapid progression measured by total kidney volume, and by the practical guide, she would qualify for tolvaptan prescription. Another risk scoring system, however, that's predominantly in use in Europe, assigns lower risk to PKD2 mutations than to PKD1 truncating and non-truncating mutations. So just to remind you that the REPRISE study, which led to the FDA approval of tolvaptan, actually only enrolled individuals whose GFR ranged from 25 to 65. And notably, total kidney volume was not an inclusion criteria for REPRISE. And genotype data from REPRISE is actually not yet available either. So how do you apply these various conflicting pieces of information to make the decision about whether or not you should treat her with the only FDA-approved medication specifically for ADPKD? So this was a study that evaluated total kidney volume and genotype in the CRISP and HALT PKD studies, where both of these measurements were available. And you can see that there's actually a range of kidney volumes and so-called Erasable class or MIC, Mayo Erasable class designations for total kidney volume. So if you look on the right-hand side, you can see the various classes of A through E indicating lower to higher risk, and then the corresponding genotype on the other side, where of course you do see that PKD2 genotype tends to have a more mild phenotype, but that there is considerable overlap in the range of PKD1 non-truncating mutations with PKD2. So there are, in other words, PKD2 patients who do have larger kidneys for, as you might imagine, there's a range of presentations within any of these genotypes. So here you can see that those with PKD2 in the Mayo Erasable class of 1C did have later onset of kidney failure. But as we discussed, there is a range of disease courses. Interestingly, the rate of growth of the total kidney volume is the same for PKD1 and PKD2 genotypes, meaning that the growth over time is the same, although the sort of starting place is different between these two groups. So you might imagine that using the argument that the attenuation of cyst growth progression by tolvaptan being the main mechanism of disease could still apply in those who fall into the PKD2 genotype and may have a slightly higher TKV at the time of assessment, falling into a risk of rapid progression. For various reasons, this patient prefers not to take tolvaptan, which I actually think is quite reasonable, especially considering all of these factors and the fact that her GFR is very preserved at this time. She personally prefers to use various dietary interventions, and she's still just coping with the new diagnosis and trying to make a decision about what we would like to do in the coming months to years. working together as a team. Okay, so my next case is a 44-year-old woman, also with a history of autosomal dominant polycystic kidney disease that had been diagnosed and treated at a different center. Her father is age 65 at the time of my first meeting with her. He also had a history of polycystic kidney disease and was not on dialysis at that time. Her mother, age 65, has no medical problems. She has a half-sister by a different father who is 33 and has no kidney cysts. She does have 2 children, including a son who has a diagnosis of PKD at the age of 13. She also has a history of hernia, but no known liver cysts. She reports occasional abdominal pain, and currently her GFR is about 89. The history of her labs showed a GFR of about 111 from the earliest time point in our system. But as you can see from this graph, the slope of her eGFR change has been quite modest over the past several years. Notably, she does have a UA positive for heme since 2009. So this is a sample of her kidney imaging, revealing relatively modest kidney sizes of about only 11 centimeters on each side. And again, calculating her total kidney volume from those measurements puts her in a class of 1A Mayo classification, which is actually very relatively low risk of disease progression in AD-PKD. So notably, her son is cared for by a pediatric nephrologist at our institution, and he's now age 17. His main issue is actually primary nocturnal enuresis that has been very refractory. And his most recent creatinine was 1.25, up from a previous range of 0.6 to 0.8. His UA is actually negative for heme, and his urine protein to creatinine ratio is fairly low. And since DDAVP is a strategy to treat enuresis, this actually has not been used because of this concern about the effect on his PKD cysts. This would be actually the opposite strategy from the use of tolvaptan, which of course is not approved for use in the age group less than 18, but by extrapolation of the mechanism of disease progression would be thought to be potentially detrimental. So his imaging is notable for a few scattered multiple bilateral cysts on MRI, and a more recent renal ultrasound showed that he had pretty unimpressive degree of cysts, and it was thought that given his age and lack of bilateral cysts, although on ultrasound, on MRI, he actually did have bilateral cysts, but that a polycystic kidney syndrome was probably unlikely. So to think about testing my patient, the mother of this child, and a woman with her own disease course, we thought that it would be informative for both her care and also potentially for her son's care if we could get a diagnosis in her, considering that genetic testing in her son directly would have different implications potentially than testing her. So pursuing her genetic testing, we found a pathogenic variant in the COL4A5 gene, making her have a new diagnosis of X-linked Alport syndrome. And this mutation would not be consistent with bilateral kidney cysts. So we don't really have an explanation of why she does have bilateral kidney cysts, albeit modest ones. Indeed, she could still have a PKD mutation, considering that in the Groupman paper that was the revolutionary paper about exome sequencing in kidney disease, about 1 to 4% of patients actually did have 2 disease-causing mutations in different genes. So she certainly could be an individual who falls into that category, and it's not clear. It is possible to miss the diagnosis of a PKD1 or PKD2 mutation due to the limitations of genetic testing of this complex gene that were alluded to by Dr. Russell. So interestingly, this variant has been described before in a family with a rather severe phenotype of X-linked Alport syndrome. And as you can see in this family tree, all of the affected individuals did have microscopic hematuria and some degree of proteinuria as well. This is a different gene altogether, and I don't mean to say that this is what could be happening in our patient, but it is notable that a lot of new discoveries are being made in just the complex type 4 collagen protein, and they have different effects that have been demonstrated not only in the basement membrane, but in other disease manifestations. And in this series of COL4A1 mutation in familial kidney disease, there actually were kidney cysts that were described. So I think that it is possible that going forward, we'll learn more about potential overlaps in cyst development from collagen 4 mutations versus you learn whether or not we'll be able to detect mutation in the PKD1 or PKD2 genes in this patient. So her clinical course was modified with this diagnosis, and she was referred for hearing and vision tests. The aortic root can be affected in PKD, and it was reasonable to get an echocardiogram also to evaluate her aortic root and valves. Her son was referred for the above testing as well, and now is actually trialing ddAVP for the enuresis. We would like to eventually confirm the genetic variant in the patient's son and father if that becomes possible, basically because of cooperation of these family members. Okay, my last case is of a 34-year-old woman with end-stage kidney disease. She started dialysis in 2018 at the age of 31. She has frequent admissions for so-called dialysis non-adherence, which unfortunately is actually due to her not having childcare during her scheduled dialysis shift. And initially, her presentation was actually due to nephrotic range proteinuria in 2007. And at that time, she actually did require, she had AKI requiring dialysis, came off dialysis briefly, but then was started on dialysis again, as I mentioned. She did not have a biopsy at the time of her presentation or at any point. She had a broad workup for glomerular disease and had a variety of negative serologies. In her medical record, chronic kidney disease that are listed as the reason for her kidney disease, including secondary FSGS from obesity, hypertensive nephrosclerosis, and quote-unquote medication non-adherence. The patient is African American, and her family history is notable for her mother also being on hemodialysis at a very young age. So to talk a little bit about APOL1 renal risk variants, there's a region on chromosome 22 that contains genes encoding the MYH9 gene for myosin heavy chain and APOL lipoprotein L1. And the last exon of APOL1 has two common variants called G1 and G2, which are in tight linkage with MYH9, and these associate with higher renal risk. High-risk variants, which are either G1, G1, G2, G2, or compound heterozygotes, who are called G1, G2, have higher risk, particularly of these conditions, including HIV-associated nephropathy, FSGS, and CKD attributed to hypertension, based on case control studies with up to 29-fold or 7 to 10-fold increased risk. The population estimates of these variants are that at about 30 to 35% of individuals with recent African ancestry carry at least one risk allele, and it's thought that at least 12 to 13% carry two high-risk alleles, although only about 20% of these individuals will have overt kidney disease. So we did pursue genetic testing in this patient in an effort to better understand her disease and her need for kidney dialysis at such a young age. and to also, to some degree, help the patient to understand why this had happened to her, and to try to combat some of the language sort of used in the medical record about her non-adherence, her supposed non-adherence, which she had been sort of labeled with. So indeed, she had two G2 increased risk alleles, indicating that indeed she had APOL1 mediated kidney disease. And her mother underwent the genetic testing as well for the same reason, and was found to actually have a G1 and a G2, meaning that the patient clearly inherited the G2 from her mother, and that her father is either a heterozygote carrier of G2, or may have either just one copy or another copy of non-higher renal risk variant. Unfortunately, we are not able to test her father to know for sure, but he definitely had at least one G2. So what does this information do for our patient? She's already on dialysis at a young age, so it's not like we have this genetic information and can predict that she's going to have disease progression or be at higher risk per se. She does not have diabetes. There has been an observation that there might be increased survival on dialysis due to reduced subclinical atherosclerosis development in individuals who have the renal risk variants of APOL1. And this was evaluated in a population of about 400 dialysis patients in whom APOL1 gene status was available. And here you can see that the non-diabetic patients with two risk variants actually had a statistically significantly longer survival on dialysis. There have also been conflicting results from other studies, but there is some scientific underpinnings to this that would suggest that there is less aggressive atherosclerotic development as a result of these renal risk variants. So how would this affect her ability to be transplanted one day, since she is so young and it is extremely difficult for her to undergo dialysis? So it's estimated that about 23% of first-degree relatives of Blacks with non-diabetic kidney disease are projected to have two risk variants. Barring potential donors with two renal risk variants could have numerous disadvantages, including further reducing access to living donation among African Americans and potential psychological distress from having a diagnosis of this risk and not necessarily having kidney disease. It might be appropriate eventually to get to a point where we actually have a method for assigning a threshold for age and assessing a risk for a second hit among two renal risk variant carrying individuals. And I'll talk a little bit more about what I mean by a second hit in a couple slides from now. So, considering that if two renal risk variants in donors really does accelerate progression of disease to end-stage kidney disease, it might be reasonable to exclude those with two renal risk variants from donating a kidney. And actually, a very small study does show about a 10% rate of end-stage kidney disease in living donors with two renal risk variants, although this is currently the subject of larger evaluation in the APOLO consortium, as alluded to by Dr. Rastogi, of which our centers are a part. So this patient was eager to have more understanding of her disease, as I had mentioned, since she was so young, and we discussed the pros and cons of genetic testing. But what are community member views on APOL1 testing? This study was conducted among 39 participants who were representative of a African-American patient population in a variety of cities in 2019. And this group expressed unanimous support for testing so-called cadaveric or deceased donor kidneys that were being transplanted. There was near unanimous support for offering testing to living donors with counseling, but sort of dispute about whether it should be mandatory or not. And notably, 90% actually opposed barring living donation from individuals with 2 renal risk variants. 64% endorsed universal testing for Black patients, although this was sort of further delineated into only about 21% favoring offering the test to those with CKD risk factors, and 10% thought that only patients with signs of CKD should be offered testing. So I mentioned the second hit that is thought to be the precipitant for kidney disease in individuals with 2 renal risk variants of APOL1. And here is a schematic describing what that means exactly, in that podocytes with APOL1 high-risk phenotypes is the first hit. And then a second hit actually is thought to be mediated by increased interferon levels. And this can be due to viral infections, for example, HIV, as has been described in terms of HIV-associated nephropathy, and also various drugs or inflammation, such as lupus. And this second hit is what precipitates the cellular swelling, mitochondrial damage, and then downstream effects of cellular disruption that eventually leads to podocyte effacement, albuminuria, proteinuria, and inflammatory response that leads to the phenotype of APOL1-associated FSGS nephropathy or HIV-associated nephropathy, seen as collapsing glomerulopathy on biopsy. So it's 2021. We're still dealing with COVID-19, and it's notable that it has indeed been shown that those with an APOL1 high-risk genotype can be susceptible to a second hit from COVID-19. So here is a series that was published very recently, given our ongoing battle with COVID-19, which shows features of COVID-19 glomerulopathy in APOL1 high-risk genotype patients, including collapsing glomerulopathy and foot process effacement. So to get back to my original take-home points, genetic testing may reveal information that seemingly conflicts with other clinical information about risk of rapid progression in ADPKD. Genetic testing may reveal alternative diagnoses, as in our second case. And I think that the future will show an evolution in terms of how we use APOL1 genetic testing, but we may eventually be able to help identify at-risk individuals, perhaps understand better how to attenuate effects of the so-called second hit, but uncertainties still exist regarding clinical implications. Thank you so much, and I know we'll get questions in the panel discussion, but you can also email me anytime at pkd@ucsf.edu. Thank you so much.
Thank you. So thank you, Dr. Park, for that excellent discussion. Just some key points that Dr. Park brought in our discussion: the shared decision-making. I think that's very important. And we'll be discussing that in our Q&A section as well. But also, so what other benefits can the gene testing or genetic testing do? One was to risk stratification, especially in our patient with ADPKD and rapid progressors, but also getting the correct diagnosis. And this we have seen, Dr. Park mentioned a few trials, including the REPRISE study as well. And we were part of those trials at UCLA. The correct diagnosis is important. Just because you have cysts in your kidneys and multiple cysts doesn't mean that you have ADPKD, and there are alternate diagnoses. And once again, we'll be discussing that in our Q&A section. But it's important to get the right diagnosis, because if you don't get the right diagnosis, you can't get the right treatment and actually can be getting potentially harmful treatment. So that's where the key is, the diagnostic portion.